Um, Hello, everybody. Welcome. Thank you for your patience. We started a little late today due to some issues with interpretation, but all good now. So good morning, good afternoon, and good evening. A very warm welcome to you all. Thank you for joining us. I am Taj Sharif, the Knowledge Management Advisor for the USAID-funded Medicines, Technologies, and Pharmaceutical Services Program, otherwise known as MTaPS. I am your co-host and moderator today for this pre-conference session on health technology assessment pathways in low and middle income countries, scaling up sustainability of universal health coverage in Asia. As we know, colleagues, all health systems face the challenge of managing and allocating limited resources. Health technology assessments, HTA for short, is one tool for making those difficult distributional calls. HTA is a means of informing systematic and transparent priority setting processes that uses explicit methods to determine the value of a health technology. The MTaPS program, along with management systems for health, developed a roadmap for systematic priority setting and health technology assessment. We will be calling it the HTA roadmap during this session. This HTA roadmap is a practical guide for policy action in low and middle income countries to successfully implement HTA and pave the road to a journey towards sustainable universal health coverage and self-reliance. So to that end, we hope that this pre-conference session will help raise awareness of the broad array of pathways, processes, policy options, and best practices for scaling health technology assessment in low and middle income countries, and also look at the policy implications in this context. To that end, we have convened all of you. Thank you for joining us. Policymakers, HTA agency personnel, people that are interested in health technology assessments, members from academia. We encourage you to please hear our speakers today and in turn share your best practices, challenges, successes, and actions to further the HTA agenda in your country. A few reminders, please. This conference is being recorded. Simultaneous translation is available in Bahasa, Tagalog, Thai, and Vietnamese. And we will have a question and answer session for the speakers. So as you listen to the presentations, please feel free to post your questions for the speakers in this chat, in the chat box. So let me just move on to introducing all of our speakers today. And first, we have welcoming remarks from Arman Sia, Coordinator for Economic Evaluation and Health Financing from the Center for Health Financing and National Health Insurance, PPJK. Over to you. Thank you.
Okay, thank you. Thank you, Taj Sharif. I will start. Honorable representative from USAID MTaPS, Indonesian HTA Committee, distinguished moderator and resource persons, ladies and gentlemen, good morning to you all. I'm grateful for all who is present within the MTaPS pre-conference entitled Health Technology Assessment Pathway in Low and Middle Income Countries, Scaling Up Sustainability of UHC in Asia. I would like to thank the United States Agency for International Aid, or USAID, and Medicine, Technologies, and Pharmaceutical Program, or MTaPS, for its support to hold this pre-conference. This is an important step forward for as both Indonesia and Asia collectively seeks to reiterate benefit basket of universal health coverage through the health technology assessment approach. Distinguished participant, in 2014, the government of Indonesia launched its largest single-payer health insurance, called as Jaminan Kesehatan Nasional, or JKN, which aimed to ensure equal access to care without any financial hardship. Before JKN, only 40% of people is protected through health insurance. Nowadays, more than 83% is protected through health insurance in Indonesia. Ladies and gentlemen, despite the success over the years, GKN has its fair share of challenges, which prompts GKN to innovate to survive and thrive. Scarce resources, especially from financing perspective, stresses GKN to not only efficient at all times, but also being effective in its implementation. Many forms of solutions have been sought to balance between the revenue and expenditure of GKN, improving collectibility of premium, refining premium rate, and adjusted benefit package are imperative to achieve sustainable GKN. To control expenditure, efficient allocation utilization review has been applied regularly to eliminate waste, especially that of happening in constant. Along this line, also come health technology assessment as policy tool to rationalize benefit basket of JKN. JKN benefit basket assessment is crucial as it determines what is covered and what's not, particularly through a robust and based on real-world evidence. During COVID-19 pandemic, we've seen trends of fast development of health technology. Vaccine being developed only less than a year, growing literatures, and treatment being tested as option for COVID-19. The arm race result in not only effective but safe treatment. However, some of it is yet to answer the question on whether such technology are deemed cost-effective. This is critical as Indonesia, as well as other countries in Asia. Healthcare system operates under the NHI, which value the best buy of healthcare treatment. This where HCA take part. Ladies and gentlemen, Indonesia has been institutionalizing and practicing HCS since 2015 through what originated as single study emerged to have become an iterative practice. From critical assessment into policy, discussion, and debate. The institutionalization in itself does not also raise awareness but instead capacity building, involving academics, hospital practitioners, and enthusiasts in the field to build stronger capacity for HTA implementation. With the same motive, we hope that HTAsiaLink and this pre-conference can generate similar energy. I give the utmost appreciation to the HTAsiaLink committee as well as its board members, which have given floor for Indonesia to hold this prestigious conference, and with itself this pre-conference. My gratitude also to USAID and MTaPS program for the support as well to the network member of HTAsiaLink. I hope you can enjoy and learn a lot at this pre-conference as we will unravel HTA best practices across the world. Thank you.
Thank you, Pak Armencia. Terima kasih. Next, we will have remarks from Ms. Shweta Saxena. She is the Health System Advisor for the Asia Bureau in the United States Agency for International Development, USAID. Over to you, Shweta.
Thank you. Good morning, good afternoon, and good evening to everyone around the world. And selamat pagi to our HTAsiaLink partners in Indonesia. I would like to thank the conference organizers for giving USAID and our MTaPS project the opportunity to hold this Asia regional workshop. My name is Swati Saxena, and I am a health systems advisor for the Asia region at USAID, and I'm joining you all from Washington, DC. My role at USAID is to determine how we can take a regional development approach to strengthening health systems. So when we scan the region for common challenges as it relates to achieving UHC, we find that countries need to become more efficient in the short run when allocating resources for the long run. And this is exactly what Pak Armansia was just mentioning in the case of Indonesia. COVID-19 has exacerbated this challenge and impacted the policy-making process as the agenda setting, policy formulation, implementation, and evaluation stages are happening now in the context of a crisis. Perhaps this is creating a window of opportunity to improve the HTA systems in your respective countries. There is an urgent need for HTA advancement as the global community has come to understand the need to build resilient health systems in preparation for the next crisis. It is our shared goal across the region to ensure that evidence informs decision-making. So today we are focusing on strengthening systematic priority setting processes, specifically strengthening capacity to conduct and use HTAs. USAID recognizes the progress so far. Compared to other regions, Asia has several existing HTA institutions, networks, and experts in conferences, but we also know that countries are at different stages. And this is precisely where the regional development approach comes into play. As we would like to support the continued advancement of institutionalizing and integrating HTAs within the policy process, we hope this workshop will allow countries at different stages to learn from each other. The MTaPS project has developed tools, including the HTA roadmap guidance, and has applied a scorecard to assess the status of HTA in countries. These tools and assessments are being used to inform technical assistance strategies in the countries that we partner with. So in the virtual room today, we have regional experts, HTA practitioners, policymakers, academia, and hopefully other development and implementing partners. And so we want to tap your collective brains today as USAID looks to the future. We want to understand your vision for which regional collaborative approaches have the potential to strengthen the capacity of HTA systems in Asia. We hope that this workshop helps participants understand how to improve transparent and evidence-informed decision-making processes, and therefore improves health system performance, value for money resource allocation, and ultimately, of course, quality and efficiency in service delivery. So thank you again for your time and the participation, and I look forward to the outcomes of the conference. Terima kasih. I will turn it back to you, Taj. Thank you.
Thank you so much, Shweta. Now, colleagues, we are ready to hear from our presenters. It's my distinct honor to introduce Dr. Christine Suharlem. He is the Health Technology Assessment Lead for the USAID Indonesia program and a Senior Technical Advisor for Pharmaceutical Economics and HTA with Management Sciences for Health. Dr. Suharlem will address in his presentation the HTA roadmap, a stepwise approach to HTA in Asia. Over to you, Christine. Thank you.
Hello, good morning, good afternoon, good evening. Thank you so much, everybody, for being here. My name is Chris Suharlem, and I serve as the HTA activity lead for the MTaPS program in Indonesia. Before we start, I'd like to kick off with some icebreaker with the slides on the screen in a little bit. We also have put together a few critically important questions for you to answer here in the Zoom poll. Okay, this is the first question. What is your primary country or region of focus for your work? Please fill among the options. And after that, we'll get to increasingly more difficult questions. Would you prefer cats or dogs? Vote which one would you prefer, work at nights or work early in the mornings? Which one would you prefer, emails or phone calls? And then we're getting to the meat of this conversation. Vote which one would you prefer, something that's precise or something that's practical? And lastly, this is a trick question. A country's existing HTA capacity strongly determines their HTA next step. So yes, as you can see how important these questions are, we are going to start doing subgroup analysis, identifying factors that affect your preference, please. I will put my votes there as well. And I think our organizers will set up some of the results on the screens. Very interesting. Oh, wow, we have a lot more dogs person than cat. Very interesting answer, and very great and insightful answers here. We'd love to start having a lot more interesting analysis here. So next slide, please. Here we talk about HTA, or health technology assessments. First, we start with some definition on health technology assessment. It is a multidisciplinary process that uses explicit methods to determine the value of a health technology at different points in its life cycle. The purpose is to inform decision-making to promote an equitable, efficient, and high-quality health system. So in here, health technology can mean many things, from drugs and medicines to procedure, tests, and many others. We'll dive down the importance of this definition, and we're so grateful today that we have Dr. Vaya Ortwine here with us to discuss the importance of this new definition. Next slide, please. We mentioned earlier that there is a roadmap that MTaPS, with the support of USAID, has developed. And in this roadmap, we discuss about the growth of health technology assessment agencies or bodies. And this starts all the way back to the Office of Technology Assessment in the US in 1975. And now it's more than, at that time of writing, it's at 33 countries, and clearly now it's growing. Next slide, please. And this precipitates the need for a roadmap. Countries are moving towards universal health coverage, but also faced with a reality that we do not have infinite resources. As such, health technology assessment is important so that we can better allocate the available resources towards the increasing demands for healthcare services. But countries do not have to start from scratch or to reinvent the wheel. There are already plenty of existing tools and resources and documented lessons and also mistakes that were already developed and documented by other countries and other organizations that we can use together to chart the country's progress for HTA. The roadmap documents, I trust my colleagues and the organizers will put the link down below in the chat. This roadmap document will serve as a practical resource guide, and this puts together all the tools and lessons all in one place to help countries take their initial first steps. The term practical guide here is important. Many countries have the aim to conduct the best possible HTA with the most advanced methods, thinking like the European countries or like other countries that have had decades of experience. We believe countries should start small. and understand the practical next steps. And this is where the earlier question, practical or precise, we want to understand what is the practical next steps given their current level of capacity. I'm also excited today. We will be here with Dr. Rabia Kavechi and Dr. Shankar Prinja, who will also be talking about the experience of Ukraine and India. Next slide, please. In the roadmap, we talk in great detail the processes for HTA, starting with the problem here at the center, and then going through all of the steps for HTA. Agenda setting, we identify and seizing that windows of opportunity for HTA. Policy formulation, looking at good practices, stakeholder analysis, clarifying the scope and purpose of HTA, and then on adoption, talking about legal frameworks and institutionalization. Of course, later today, Dr. Rabia Kavechi will also discuss the experience of Ukraine and surrounding the legal framework and institutionalization of their HTA body. Next, here on the slide on implementation, methods, guidelines, reference cases, and capacity building, and impact evaluation, so that we know whether or not the HTA is working. Next slide, please. As you see in the roadmap, we discuss all of the previous aspects in great details with 6 chapters roughly mapping to the process before, so that HTA bodies and HTA agencies and HTA champions can follow through and follow the process towards this starting small for HTA. Next slide. I also highlight here some of the tools that we explored. First, here on the top left is the Kingdom model, understanding the dynamics of problems, policy, politics, problem, policy, and politics streams, and then learn how to identify and seize that window of opportunity for HTA. On the right here, we have the Walt and Gilson model, which help us understand the context, content, and processes and actors that surrounds policy formation. And in the bottom here is you see an example of a stakeholder mapping and analysis, so that we can understand the dynamics, incentives, powers, and positions of different stakeholders. All of these are some of the tools and resources that already exist out there that we put together in this practical guidance for the roadmap to support and help HTA champions to move forward in their journey. Next slide. This roadmap was developed, started from a systematic review. We looked at close to 19,000 articles, not only published peer-reviewed journal, but also gray literature in English, French, and Spanish. We did all the qualitative analysis of the literature, and then we supplemented by the feedback and contributions from global experts and from various institutions. These are also co-authors of this document, and I'm so pleased to see a lot of them here on the joining us today. We are very proud of the truly global collaboration that makes this resource available. Next slide. There are some of the things that we discuss in the roadmap that I'd love to just quickly touch here. First is methodological consideration. In the table here on the slides, you see 6 studies, all looking at hemophilias. All 6 analyses are not standard. They have different assumptions. As a result, the final recommendations are not the same. It's important to have methodological guidelines so that when there's any differences in the results, it reflects the differences in the data. It reflects the differences in the country and context, and not because each researchers do things differently. I'm also so glad later today we have Dr. Shankar Prinja, who will also discuss India's work in standardizing the methods so that they can come into a more unified, uniform methodological guidelines. In the next slide, we also wanted to note that not all methods are equal. You see here on the left, peer referencing and cost utility analysis have different amounts of resources that's needed in terms of the information requirements and also the level of effort that is needed to deliver the research itself. As countries have limited resources, limited data, limited capacity, we have to think of what is the most practical steps for countries to conduct HTA. We, as I mentioned before, believe that starting small will be more beneficial than conducting the most sophisticated modeling work on day one. On the right here, you see we also discuss in the roadmap the Drummond method to adopt or adapt cost effectiveness analysis that was already conducted in different contexts or different countries. With these methods, it helps us think through how can we use the lessons that's already created by others to make that applicable to our context. On the next slide, we'll discuss a little bit the recommendations of the roadmap. We see countries have different level of capacity for health technology assessments. Some countries have pretty much no or very minimal capacity for HTA. For those, our recommendation is to start small and do peer referencing, rapid reviews, costing work, etc. For others, I expect as the audience of today's sessions, many countries have some level of HTA capacity in the country. For these countries, we still recommend conducting the low-hanging fruit, so to say, the peer referencing, rapid reviews, costing and budget impact, things that require less amount of resources, less amount of effort as well. But at the same time, this is also the perfect opportunity for countries to start slowly building capacity for more sophisticated analysis. We're thinking about cost effectiveness analysis, sensitivity analysis, and many others. This is also the time where we have a lot of emerging and growing HTA capacity to start building connection amongst the different pockets of HTA doers, so that resources can be channeled more optimally, and we also can limit the duplication of efforts. Lastly, on the bottom here, for countries that has more robust HTA capacity, in addition to the methods that we mentioned before, we also believe that a more sophisticated methods, including MCDA or multi-criteria decision analysis or cost utility analysis, a lot of these would also be more appropriate. Next slide. Here is the last slide that I have here, which is our newest development in the area. We did a systematic review until April of 2020, and we surveyed HTA experts in the Asia region. We conducted semi-structured interviews, and then we charted the status of 9 Asian countries among 18 milestones, as you see here on the screen. These 18 milestones were developed by our colleagues at HTAP. They've put together a set of indicators, and in our research, for each of these indicators and for each country, we score countries from 1 to 5. 1 being no progress or very limited data to indicate there's any progress, and to 5, which is significant progress on milestone and high quality ongoing use of HTA and has a close connection to decision making. So it's not simply a progress on the milestone. We also want to look at the progress, the quality, and the applicability and the practicality of the work. So we score countries from 1 to 5. You see here for each of the 9 countries, the scoring amongst the 18 milestones. The purpose of this work is twofold. First, we want to help countries to look at their peers in the region and also see which aspects of HTA that they can learn from one another. And second, this also helped create a baseline for which future HTA progress that country can chart so that the countries can identify areas for improvement and see growth over time. I will not go into much detail for this specific study and research. Our colleague, Dr. Ana Amaris, will also have a dedicated oral presentation session on this specific topic in the main conference. So I would refer you for that presentation, but wanted to give you a flavor of the balanced scorecard assessment that we recently did for the Asia region. I think this is my last slide. Thank you so much for listening to my presentation. I hope this was useful, and I give the floor back to Taj. Thank you very much.
Thank you, Christian, for that insightful presentation. Next, colleagues, we will hear from Dr. Vaya Utmai on HTA in support for universal healthcare beyond benefits package design. Vaya is the president of Health Technology Assessment International, HTAI. She's also a senior researcher at the Radboud University Medical Center, UMC, and an associate professor at Leiden University Medical Center. Welcome, and over to you, Vaya.
It's actually an honor to be with you today. I'm based in the Netherlands, so it's a bit early, but it's a pleasure to be here today and share my experience and also to learn from you. And what Tosh was saying, indeed, it's an honor to speak also on behalf of the Health Technology Assessment International and share my experience that I do as a researcher based at the Radboud University Medical Center. So can I have my next slide, please? I would like to speak to you today a bit indeed about the definition of health technology assessment, as well as the purposes of using health technology assessment. And then I will come back to the roadmap that my colleague Chris just introduced to you. Next slide, please. Chris already mentioned to you the definition, which is on this slide. And I would like to highlight a few concepts in this definition. First, it is the life cycle of a health technology that is central in this definition, as well as how HTA can be used to inform decision-making. The roadmap that Chris was introducing is mainly focusing on priority setting and mainly to define the benefit package. But with this definition, we also focus on decision-making in other contexts, but also focus on decision-making for other purposes. I also would like to underline that this definition that was published last year is an international aligned definition with an international joint task force that was co-led by the International Network of Agencies for Health Technology Assessment, which is INATA, as well as Health Technology Assessment International. We established this definition in close collaboration with all regional networks, including HTAsiaLink, UNETA, the European Network for HTA Assessment, as well as with REDETSA, which is the network for the Americas, ISPOR, and also with endorsement of WHO, as well as Euroscan. So this is the new definition, and I do hope that we all across the globe are using this definition from now onwards. I like to say that this publication is still the most read publication in the International Journal of Technology Assessment in Healthcare, so I'm pretty proud of this. But it's also a milestone, I think, that all the networks were collaborating together. And I think that's also why this event is so important, that we can share and learn from each other across the globe. I also would like to note that health technology in itself is not only focusing on drugs or medtech, but also could include different kinds of other technologies like vaccines, procedures, programs like vaccination programs or other public health programs, or even systems. So it's quite broad. Next slide, please. So if we focus on the life cycle of technology, and this slide is actually based on the technology of a drug, but this could also easily apply to other kinds of technology. I think it's very important to understand that health technology can play a role in each phase of the development of the life cycle of health technology. So you could use health technology, for example, for identifying important products or technologies that could potentially be disruptive for a health system that you would like to be notified of, especially when you have scarce resources. You need to focus on those technologies that potentially could be important for your region or your health system. And I have noted that my colleagues from Euroscan, now called HTAS, also have a pre-conference workshop later today. So if you are interested in horizon scanning, you might want to attend that meeting as well. So it's not only used for reimbursing drugs or other technologies, but also for example, for the procurement and for the establishment of clinical guidelines. And I do know that my esteemed colleague, Dr. Cavecci, will also talk about these uses of health technology assessment. But last but not least, I would also like to underline the importance of health technology assessment after it has been reimbursed, a certain technology has been reimbursed or is used in practice. You might also want to look how appropriate the use of a technology is. And if it's not appropriate, then you might want to determine to disinvest a certain technology. And this is actually something that is increasingly being discussed, not only in high income countries, but also in lower middle income countries, because we only can spend our money once, and we want to spend it wisely. And therefore, you might want to see where in the system there is waste. So, as you can see, HTA is multi-purposes, and not only for the use of reimbursement decisions, but also for other kinds of for other decisions, and not only at the macro level, but it can also be used, for example, for hospital-based HTA, and there are also countries across the world that are using HTA for this. For example, also in Kazakhstan, this is increasingly used, and I saw some of my colleagues from Kazakhstan also attending this meeting, and I've been working with them quite closely. So next slide, please. So when we talk about informing decisions, like I said, it can be used for different purposes. So not only for reimbursement, but also for the establishment of clinical practice guidelines, for planning and budgeting, quality of care, and for example, also for determining, for example, essential medicines list. And this is a slide that comes from colleagues from WHO who did a survey some years ago, which clearly also shows that there might be differences between countries for how they use HTA in informing decisions. This slide is a bit old, it's 2015, and they are currently updating this survey. And I do know that my colleague from Ukraine, Dr. Cavecci, also will touch upon this. But this is just to show you that high-income countries were mainly using HTA for determining the benefit package. But of course, this is now changing, because also with the strive for universal healthcare coverage, also more and more lower middle income countries are using HTA for determining the benefit package. Next slide, please. This is also being said by my colleague before, that HTA is clearly linked to the decision-making process. And in order to set up HTA, you probably need to think upfront how you would like to use HTA. So the mandate, and that's why I underline it here on this slide, is very important. So are you using HTA for determining the benefit package, or are you using it for procurement, nomenclature, or for example, for clinical guidelines? This is very important also in terms of how you structure and how you would like to govern your HTA system in a region or country, or even smaller in your hospital, for example. So the mandate or the purpose of HTA also definitely influence the institutional setup and the capacity of your HTA system. Both my colleagues from India and Ukraine will talk about the institutional setup and also about the legal frameworks, why this is so important that you have that up front. But like I said before, also the identification of technologies in need for HTA is very important. Once you have your structure, your governance, you might also think about whether or not you would like horizon scanning to be part of your HTA process, yes or no, and how to set priorities. I do know that both my colleagues from India and Ukraine will also talk about how they have organized the assessment part, which is of course how to do HTA, as well as the appraisal. How do you define indeed, or determine, or make recommendations with regard to which technologies to reimburse or not to reimburse, is very important. And also what Chris was saying, monitoring evaluation is very important in HTA, which is most often forgotten. I think this is actually, the monitoring evaluation of HTA is actually, I would say, an added value of those countries or regions that are setting up HTA, because this is actually fundamental in how you make clear what is the added value of health technology assessment for those who are accountable for HTA. And in this whole process, engaging stakeholders is fundamental. So not only at the end when you determine your decisions or your recommendations, but also in the structure and governance and how you set up your identification processes as well as your priority setting. Stakeholders from the beginning engaging is fundamental in making legitimate processes, as well as also to have fair processes in place. And I think this is also part of why certain processes are successful in certain areas and why not. Because in the end, you need to have buy-in from those who will make the decision. So it's better to think about that upfront than at the end. Next slide, please. So when we talk about all of this, I like to show you this slide. Is a lot of countries do already have a kind of institutionalization in terms of an HTA agency or an HTA body. And this is a slide that I took from the website of the International Network of Agencies for Technology Assessment, INATA. And these are members of INATA, and it means that these are public agencies, or those agencies that are at least publicly funded for more than 50%. And you can clearly see on this slide that especially in Western Europe, there is a huge concentration of HTA bodies, and that those around the globe are more dispersed. And I find this a very interesting slide because you can clearly see that those countries with a high level of GDP spending on health do have an HTA agency. Well, of course, we would like those that have less to spend on health also use HTA for their countries. And yeah, I think this is very interesting. Like Chris was saying, those that are most in need of HTA often are still at the very early stages of institutionalizing HTA. And I'm pretty well, I would say I really would welcome this roadmap, because that really helps also countries to institutionalize HTA in their countries as well. Next slide, please. And in terms of what this means for low and middle income countries, we often look at countries that have already established HTA systems. And these countries, here you can see Australia, Canada, Brazil, England, and Scotland, are often seen as best practices, and we often refer to those countries when we look at how to set up systems. But what we also should note that there is no single country across the world that could be seen as a best practice as a whole, because every country is struggling with their own HTA processes, and they also are trying to optimize their processes constantly. So what we were seeing with monitoring evaluation, it is very important to understand that also, for example, countries like the Netherlands, where I am based, but also Canada, for example, are now looking at their HTA process, and also NICE, by the way, in England, how to make their process more robust, more transparent in terms of engaging stakeholders, and make it more deliberative in order to come to fair processes across the whole life cycle. Also, I would like to note that please do not copy any of these systems when you're trying to set up your own HTA process in your country, because you should understand that all of the HTA processes are very context dependent. You have to look at the organization of care in a country, the financing system in a country, and of course these are all different across all of these jurisdictions. So you can be inspired and we can learn from each other, but we can never copy paste any other system from one jurisdiction to another. And I'm pretty sure that Rabia Kaveci will also talk about this. Next slide, please. So what can low and middle income countries learn from this? We should look at what are the challenges. The challenges for low and middle income countries, and I've been working in a lot of low and middle income countries myself, and I'm still working in a lot of middle income countries, is that the political and economic context is very different. We should understand what are the health needs of a country before we are setting up an HTA system, and the HTA system should align with these priorities. We should also understand the financial situation in a country, because the financial situation in a country also determines what you can spend on health, but also what you can spend on health technology assessment, and also where you should put your resources first. So this is very important to understand. You cannot spend money that you don't have. So if you have a very small budget to be spent on health, and then you want to set up your health benefit package, then we should be very careful about what we can buy for that GDP per capita spend, and how much people have to pay out of pockets in order to obtain also the financial protection of a country. So first, please try to understand what is the situation in a country, what are we aiming for. Also, I think my colleague Chris also mentioned this, the capacity is very important, but even more important is also the data that is available. And the data is also also influences the robustness of the system that you're trying to set up. So I think this is also very important. And there might also be a certain regulation in place that might also hamper the institutionalization or the HTA, and this is, for example, the case in Latin America. And I saw some people from Latin America also on this attending this conference, so they might also want to speak about the judicial enforcement of health rights and how that can influence HTA. And then my last slide is about indeed encouraging you. Can we go to the next slide, please? I don't see my last slide, but my last slide was actually about what my former colleague also said, that we should start small in low and middle income countries, and be attentive of the financial situation that we do have, and that we should indeed be inspired by each other, and that we should learn from each other, and that this conference actually is a great opportunity to share our experience that we have, and to collaborate with each other. And I would like to thank you all for your attention, and I will give the floor back to Josh. Thank you very much.
Thank you, Vedant Vaya. You've been up all night and it's almost 5 a.m. your time.
Okay.
We really appreciate having you. Honor and a pleasure. Just in the interest of making sure that, that Vaya can, if not go to bed, at least get some rest. Let's start with you with a question. Income levels, have varying needs for HTA. Some for budgeting, planning, but others for reimbursements. So within a specific income level, do you anticipate the needs to be uniform, or do you think that these needs should be customized for every country? Thank you. Over to you. Sorry, you're on mute. Yes, go ahead, please.
Thank you so much for your question. Well, I think you're right. I think that this has to be customized for every context, because every context is different, and it's up to the countries to decide how they wish to use HTA. And yeah, so it's that's the answer, I would say. So you could also see actually on the slide that the countries do use HTA for all these different purposes, but there was a dominance for using HTA for determining the benefit package in high income countries. But I think that has changed now, because with the Sustainable Development Goals, I'm pretty sure that this will also, as inspired low middle income countries use that for HTA as well.
Thank you. Next, Christian, question for you. So how do we support countries with low or very little HTA capacity to sort of undertake the HTA methodology that their peers are undertaking? Those peer countries with, perhaps higher HTA capacity. Over to you, Christian. Christian,
yes,
can you hear me?
Thank you.
Yes.
Yes, thank you. Thank you for the questions. I think there's always this sort of tension between the available capacity and the level of ambition where we want to go in the near future. I think there is clearly every country should want to strive for to be able to conduct HTA in the best possible that they can, and many of that would have sort of a North Star or a gold standard. But as Dr. Ortwine mentions, all countries are having their own journey, and sometimes we have to also put into perspective that the peer country that might be next to us already have 20, 30 years of experience and there's a learning that's involved with it, and there's also mistakes, and there's also lessons learned that they've already shared that's already happening throughout all of this decade. So that's why when we are providing our recommendation based on the systematic review and also from the global experts that are joining us at for the development of the roadmap, we also want to see in terms of the practicality. Sure, we all want to be as precise as we can, but at the same time, we do have very limited resources. When we're talking about low and middle income countries, they have limited number of experts who each of them only have 365 days a year, right? And then we also have limited number of resources that can be mobilized to gather data. There's sometimes, in many cases, very limited available data sets or centralized data that is available for researchers to be able to tap into. So I think in this case, there's a lot of this tension between you want to be able to produce the best possible HTA with the most advanced methodologies, but at the same time, resources are limited, and therefore countries would have to make the tough choices, precise or practical.
Thank you, Christian. Thank you. We keep coming back to that being precise or being practical point. And so moving on to the next set of presentations. Now we'll hear from Dr. Rabia Kavici on institutionalization and legalization pathways for HTA. Dr. Kavici is the Vice President at HTAI, Health Technology Assessment International. She also serves as the Senior Technical Advisor on Pharmaceutical Policies and Governance for the USAID-funded SafeMed project. Over to you, Rabia.
Taj, for the introduction, and thanks for the colleagues, Valia and Chris, who set the ground for my presentation. It's an honor and a pleasure to be here with you, with very distinguished colleagues. I wish I was there physically in Jakarta, but unfortunately today we have to do it virtually. As my colleagues mentioned, it's extremely important to inspire from other countries, to look into what other countries have done, their success stories and their failure stories, to listen to them. But it's always very important to have everything contextualized. So here today, I would like to talk to you a little bit about a case study from Ukraine. So Ukraine has been actually a very good example how it started and institutionalized and legalized HTA in its health reforms in a relatively very short time. So I think we will have opportunity to look deeper into this. But as I said, it's very important to hear this, but then discuss internally what could be applicable to our own setting. Next slide, please. Here in the slide, we see a summary of development of HTA function in Ukraine. Well, in Ukraine, actually, by beginning of 2019, HTA department was established. So it's basically 2 years, 9 months that we have HTA structure in the country. But it doesn't start as Chris mentioned, actually, that there's the ground first and then the structure starts, and usually the best is to start it small. And what's happened in Ukraine? First, you need to have the ground to start this. So in Ukraine, there was interest, there was the reform, and there was strong desire for universal health coverage. And in this setting, the public, the MOH decided to increase capacity building. First selected a group of experts, and USAID funded SafeMed projects, supported also capacity building program. And then the capacity for this select group of experts were improved, and they were trained for HTA. And the main task they had to do first was to work on EML, first essential medicines list for the country. So HTA was first used in this way. And it was successful, the interest grew, and by January 2019, there was a small department established under State Expert Center, which was a state enterprise of the MOH. And this is how it started. But what happened? We have more than 2 years, almost 3 years history for HTA in Ukraine. And here, with the department up to now, there's always continuous capacity building. So it's not like you build up a capacity and then you stop, because your ambitions, as Chris said, I think it's a very good citation I have to make. Our ambitions are too much, but our capacity is not always matching this ambition. The same is for our budget. Like, for example, Ukraine is a lower middle income country, and in Turkey, where I am from, it's also a higher middle income country. So in these settings, you do not have a huge budget, but you still have the ambitions of high-income countries. So this doesn't always match. This is always the case, unfortunately. But what happens throughout the years, by the way, I see the notes about blurred slides. I have no control on them, so I'll kindly ask technical team if they can do anything about it. But I'll just summarize. It's too much reading, don't worry about it anyway. So the thing is, what has been done is first capacity in parallel, but what is important is to show how HTA can help, because HTA should not remain as a theoretical exercise like, okay, these countries do HTA, so we need to do it as well. No, you first need to understand what's important in your country and for which policies you actually need HTA, how it can help. And when you start doing it, you need to prioritize certain policy decisions where you can show the support of HTA. This is what was done in Ukraine. So after the department was settled, there was lots of pilot studies with HTA department people being involved, such as central procurement, regional procurement, or affordable medicines program, and so on. So in the first 2 years, it was mostly about engaging HTA colleagues into decision-making process, but not all of them was totally legally supported. So it was mostly like piloted and voluntary basis and with the political support. But what happened? 2 years later, there were so many success stories how HTA can help, and the legal next steps were taken. By the end of 2020, there was a cabinet minister's decree that made HTA mandatory in the country. And now it's 9 months that it is mandatory, and the HTA department receives dossier from industry to review them, critically appraise, and may build up their own recommendations. And in parallel, MOH can also ask HTA department to do assessments for certain cases. So next slide, please. For the organizational model, in this department, when it was established, there were around 30 people in total, and around half of them focusing on HTA. So the department itself, I will also show you some examples from European countries. Not always the HTA function holds only HTA, but they can hold also additional tasks. In this case, it's like the protocols and registries. So protocols and registries are also responsibility of the HTA department in this case. Next slide, please. Here is a summary of how HTA is used in Ukraine. So as I mentioned, after the department was established, the HTA was slowly integrated into the decision-making, and which includes like benefits package, which is under responsibility of NHS. So for benefits package, actually via Ortwine, she also supported us in Ukraine to draw up the strategies, how to actually include HTA in building up the benefits package. But this is only one example. The second one, affordable medicine program, we call reimbursement program, where you can get medicines from the pharmacies based on the prescriptions. And here we started to use HTA as well. And the other one is central procurement, what medicines should be procured at the central level and what are allowed to be procured at the regional level. So HTA also started to be used for those ones. What is being discussed is public health interventions. Currently, it's not used, but we already started the discussions, how it can help and how it can be used, like for vaccination programs or screening programs, is moving forward. HTA can be used for clinical practice guidelines or quality, improving quality and patient safety in the country, but these are to be improved areas. Next slide, please. Next slide, please. Thank you. So here's also a summary. So how we started. In 2017-18, so it's 5 years story up to now, HTA first without being formal department, it was used for essential medicine. It starts to support nomenclature, which is for central procurement, and benefits package program under NHS agreements with hospitals. And this year, the discussion for supporting all these activities, which ended up with separate lists. Having an interesting policy right now, I think this is a very well established pricing strategy for the country, which makes recommendations and decisions a little bit harder. For managed and trade agreements, it's quite important. Establishing HTA, the country also worked on legal ground for managed and trade agreements, and now the country is ready to conduct its first agreement by next month, actually. The challenges for moving forward is how to use HTA for vaccines or other non-drug technologies, such as devices, equipment, or public health interventions. It's in the plan for next year. Next slide, please. I want to give you a summary of the legal framework. So everything started with the law, because without having a good legislation in place, it's not possible to clearly integrate HTA into the decision making. So it started with the law. The law about state financial guarantees of medical services. This included a statement talking about HTA and engaging with HTA, but it was just 1-2 sentences in the law. The following Cabinet of Ministers of Ukraine decree, exactly 1 year after the law, included a bigger section that HTA should be officially engaged and the decisions should require HTA recommendations. This was not like a mandate, but it was more of a recommendation nature. And this is the basis where HTA department was established. And exactly 2 years from this establishment of the department, there was a new decree making HTA mandatory for all pharmaceuticals. And those 2 years is the opportunity window period that I observe not only in Ukraine, but also in other countries as well. When there is interest, there are some successful little stories about HTA, and there's the momentum and political will. This is actually the time that you can move very quickly on legalization and institutionalization. And the next step, when you have law and the decree, of course, you need to have internal MOH orders that defines the process from assessment to appraisal and to decision making, the timelines, who should be involved and what should be their roles. So this is under public discussion now, which is expected to be accrued very soon. And another, again, what we need to do with respect to having a formal process is that the department itself has to have very clear internal processes, how they conduct this. And these are always updated, renewed, and adapted to developments. And very important thing here is HTA guidelines for medicines. For the first time in the country this year, it was published, and now all HTA is based on these guidelines. Next slide, please. Here's a summary of the roadmap. So what Ukraine did, first, when the department was established, there was a roadmap 1.0 version, which covered 5 strategic directions And this was until the clear legal decision. So when we build up the roadmap, the idea was until there's this certain legislation in place, what we can do. This includes first having a strong HTA structure, fully functioning HTA entity that we prove internally. We know our methods, there's a model, and we know our strategy moving forward. So the function is strong. And the second one is there is the ecosystem where you can engage HTA into this decision-making ecosystem. And the other directions are capacity building, where you have continuous increasing capacity in the country. The legal framework, the drafts are there. There's stakeholder engagement to understand what could be the best way moving forward. And there's a communication strategy in place for the department. So these were the 5 directions. And within 2 years, when HTA became mandatory and there was a clear decree, then we added here the 6th one, because decree also said that within 1 year, there should be an independent HTA agency. So we added the 6th direction, which is to define the transition strategy from the small department to a bigger entity. And this is each step, each direction includes actions and sub-actions. But this is also based on the roadmap, the major our site reference document that Chris kindly presented to us. Next slide, please. I want to give, not very detailed, but just to give you an example. If this is a country moving forward, whether it's in the beginning or you're thinking about a transformation in structure, it's always good to have options analysis. So this is what we also did for Ukraine before making a decision for independent agency. The MOH looked into the options and they found out that there are 5 options, whether to keep it how it is, like a small department, or to have an independent agency connected to MOH or independent agency connected to NHS or small departments within these structures. So there were 5 options. And in the next slides, we see that, next slide, please. Here we see for each option, we worked on pros and cons of each option. And this was discussed by MOH, within MOH, but also with broader group of stakeholders to understand what option works better. And the latest decision is to have an independent agency connected to MOH, and there will be a transition strategy from the department until this one. Next slide, please. I want to give you a few examples from European Union, but before that, just to summarize, Ukraine is just an example. It's a lower middle income country, but with ambitions of any high income country to make all innovative medicines available for their country. But this ambition and the resource doesn't match. So what we need to do is to have a rational process to prioritize what we really need to make available for our country. And what is important here is, as I said, there are the ambitions, but the reality is not everything in those countries that we sometimes benchmark ourselves are actually applicable in our countries, but also is not always the value, but does not always provide the value. So here, this report, there's a report I want to summarize here from Julia Kamova from 2017, which summarizes HTA in European Union countries. And this one shows that even the countries we see, they're very similar to each other. This is how we see when we look from outside. They're very high income countries, very well developed healthcare systems. And we see that even they differ a lot from each other. We see that 25 countries in EU use HTA for reimbursement of medicines, whereas 20 of them use it for pricing decisions as well. And 20 countries use for medical device reimbursement, 9 countries medical device reimbursement. So not all countries use HTA not always for all reimbursement decisions or all pricing. So the country, each country defines HTA process for which technology they will use and for which type of decision. In the next slide, we see that also the countries differ a lot in their processes. So here are the countries from high-income countries, which they don't have, not each of them has guidelines for submissions, for example, in the same way. Or the initiation of HTA doesn't always come from the MOH or an external resource. So it's different. And in some, there's appeal process, in some don't. So we see that process is different. In the next slide, we see that the final recommendations can also differ. So for the same medicine, for same indication, still countries can recommend it differently, whether it's a different set of patients, whether it's complete reimbursement or partial reimbursement, etc. And even how they find the benefit for the country is a lot different from each other. And in the next slide, we also see that the durations differ in these countries. It might take, in Germany, less than 200 days, whereas in Spain, it could be more than 700 days. So this also depends on the expectations, how it feeds into decision-making, and resources or priorities. So in the next slide, and will be my final slide. Next slide, please. The HTA bodies, also in these European countries, can have different tasks as well. It's not always, as I said, only HTA function, but some countries might have clinical guidelines, some horizon scanning, some might also host registries, or can host some quality activities as well. So it is different. So what we need to do in our settings, we always need to see what resources we have, what priorities we have. We need to identify the direction we will go. And this is how we are going to establish our own system for our own context. The other countries are always very inspiring. We need to look into them, talk to them, where such meetings we're having today are very good platforms to realize this. But always and always, we should go back to ourselves and look into what is the best one for our country. And this is how I finalize my words and will give the floor to Taj. Thank you very much.
Thank you so much, Rabia. We know you're on annual leave, well-deserved, well-earned. So we really appreciate you taking the time to present today. We have a quick question for you, and then we'll move on to the next presentation. So the question we have for you is as follows. So different cancer technologies receive different analyses and recommendations from various countries. How did Ukraine learn from these conflicting bodies of evidence? Over to you.
Okay, thank you. Thank you for the question. It's a very good question. I will connect it to transferability, basically, whether all these decisions are transferable and any process or any evidence that take countries to decision making, are these transferable? For the Ukrainian context, I think we identified a lot what could be transferable from other countries, but in reality, the decision itself is never transferable. This is very important to see. The decision, whether it is positive or negative, it cannot be transferable. And the thing about the evidence, usually, of course, for the clinical side, when we refer to randomized controlled trials, it could be seen as a transferable body of evidence. But on the other hand, when it comes to, we understand the value of real world evidence now. And when it comes to that type of evidence, of course, this is about the real world and it has to be from the context we have. And for the costs and that type of evidence, it again has to be contextualized. So my recommendation would be, of course, looking into other countries, which type of evidence they used, and how they conducted their processes and methods, and how they ended up in the decision to look into this, but still critically look into the details of this process and adapt it to our own context. Thank you.
Thank you so much, Maya, for that response. Much appreciated. And now, colleagues, we're moving on to the last presentation for the session. This is from Dr. Shankar Prinja, and he will speak to HTA institutionalization in India, the journey, success, and challenges. Dr. Shankar Prinja is the additional professor of health economics in the Postgraduate Institute of Medical Education and Research in Chandigarh, India. Welcome, Dr. Shankar Prinja. It's such an honor to have you here with us. Over to you.
Thank you very much to the organizers, and thank you, Taj, for this introduction. I'll just wait for my slides to be there. Yeah, thank you very much. Can I have the next slide, please? Yeah, so I'm going to talk over the next 15 minutes to try and describe to you the Indian story of setting up the HTA agency in terms of how it was done, what was the kind of process that was being used, and also some of the methods that we've been using. And then I'll move forward to describing some of the achievements over the last 3 or 4 years, and what challenges do still remain. Next slide, please. Yeah. So basically, we started our journey not very long back ago. It was about 2017 when the discussions about setting up of a HTA body in India started to take place. And this was preceded by the national health policy that was announced, that came out in 2017, which clearly specified the need for having HTA to guide evidence-based policy decisions in the field of healthcare. And since this policy's recommendation on use of HTA came in, there were different models that were being considered for setting up of the system for health technology assessment in India. Next slide, please. So basically, as you can see on the right side, there was a board that was created. And this board, which was initially called as the Medical Technology Assessment Board, was then renamed as Health Technology Assessment Board, because some people felt that having it just as a Medical Technology Assessment Board perhaps might give a orientation about the relevance of this decision-making body only for some medical care needs, but it was for healthcare needs, which also included preventive interventions. So as a result, the name was changed to Health Technology Assessment Board. And this, the secretariat of this, the HTIN or the Health Technology Assessment in India is housed within the Department of Health Research, which actually falls under the Ministry of Health, but sits at a bit of an arm's distance from the ministry. So this is the secretariat of the HTIN. And then the secretariat is guided by the Technical Appraisal Committee, which was set up, as well as a Project Appraisal Committee. And then the HTIN functions as a kind of a hub and spoke model, where there is a central secretariat within the Department of Health Research, but then there are a number of multiple spokes that exist across different states of India. And these are the technical partners and the regional resource centers. And these are the institutions which are either academic institutions or research organizations or which actually carry out the role of conducting the assessments. And these are institutions where the studies for HTA are commissioned by the Secretariat. Next slide, please. So you can see on this map, there are quite a number of institutions, more than 26 institutions that are listed here. And these are the range of different resource hubs and the technical partners which conduct HTA studies. So as you can see that there was a concerted effort towards trying to have a kind of a regional spread and distribution of all these institutions. Next one, please. Yeah. So before I begin to explain to you the process and the methods, just a quick snapshot of what's the kind of healthcare delivery structure within which the HTA functions. So there are, as you know, that in India we have a federal structure of governance. So within the health also there is a strong federal structure. The health as such, as per the Indian Constitution, tends to be a responsibility of the state government, but then the central government plays the role of oversight and providing the broader policy umbrella and setting the broader processes. Although there are few specific subjects that still fall under the central control, but by and large, there are majority of the implementation and the financing also takes place at the level of the state governments. But at the central level, we have the Ministry of Health, which deals with most of the preventive healthcare programs, as well as maintains the entire large network of public hospitals that provide healthcare services. Then we've recently created a National Health Authority, which runs the National Insurance Program that is called as the Ayushman Bharat Prime Minister's Health Insurance Program. And then we have the policy think tank, which is called the Niti Aayog. And then we have certain social security organizations, the agencies that maintain the social health insurance and the central government health insurance as well. So these are some of the agencies at the central level, and the corresponding institutions at the state level also exist, which ultimately are the users for the evidence that the HTAIN or the Department of Health Research generates, which is shown on your right side of the slide. So on the left side, these central and the state institutions become the user departments, and these are the departments that submit the topics and nominate a particular topic for conduct of an HTA study. And on the right side of your slide, where you see the Department of Health Research, we have the Secretariat of the HTAIN, which selects the topics and then commissions those topics to either of the regional resource hub or the technical partner. So that's how the organization exists. Next slide, please. Yeah. So as I was mentioning, that all these user departments which exist at the central level or at the state level, these agencies, which could be either implementing agencies or regulatory agencies or agencies that control the finance for utilization of healthcare services, these agencies nominate the topics. The Secretariat of the HTAIN ultimately, with the guidance from the Technical Appraisal Committee, does the job of topic selection, which is basically determined by the extent of importance of a topic given the incidence or prevalence of the disease condition that is being evaluated, you know, the economic impact of the given condition on the household, the extent to which the public money decisions are being influenced by the HTA study. That's also another important consideration that is taken into consideration. Next slide, please. Yeah. So once the topic is received, the Technical Appraisal Committee, it reviews the topic, and once found suitable for undertaking a full HTA, it is then commissioned to either of the regional resource center or technical partner, which develops the proposal, does a round of consultation with the Technical Appraisal Committee and the stakeholders. And once it's approved, then the HTA assessment is conducted. Then the HTA study is reviewed for the technical appraisal of the methods by the appraisal committee. And once it is done, then the final report is also presented to the TAC, as well as it is discussed within a broad group of stakeholders, which come from the public sector, the private sector, the civil society, as well as some patient representative groups are also included as part of the stakeholders. And once this is finally approved by the TAC, the final report is put up to the board, which is the HTA board, and this gives the final recommendation to the user department. So that's the kind of process that is followed in order to do an HTA study. Next slide, please. But very early on, when the HTA systems were being established, we realized that there were a lot of methodological variations that existed prior to the setting up of this formal structure of HTA in India for conduct of economic evaluations. And we found that there were various methods with regards to either the perspective being used, the way in which consequences were being valued, or the time horizon that was being used, or even the rate at which you were discounting the future costs and consequences. So as a result, next slide, please. We felt that there was a need for kind of harmonizing the methods. And this was not just in relation to the methods that were being used, it was also in relation to the way in which the outcomes were being reported. So there was quite a lot of heterogeneity in terms of the methods being used. And the slide shows you the proportion of the studies that did not follow certain quality benchmarks in terms of various types of things that you would consider as something standard in terms of reporting. And so the proportion of the bar represents that each of these things were not actually accounted for in the report. Next slide, please. So in order to set the systems right, there was an effort done towards standardizing these technical processes as well as the consultative processes that took place in order to reach to a full HTA. So there was a manual that was created which tried to specify the entire process and flow of the activities that was to be carried out. It also had a chapter that specified the reference case and the standard methods that were to be adopted by the different institutions that conducted the HTA study. There was a separate guidance document or a handbook that was created for the purpose of costing. There were guidelines that were created for conducting budget impact analysis. And then finally, there were process manuals that were set up, that were drafted, and quality guidelines were developed in order to assess the quality of each of these HTA studies. Thank you. Next one, please. And then alongside, it was also felt that there were a lot of data gaps that existed, which meant that a given HTA study that could have been completed in, let's say, a reasonable period, HTA assessment. One of the important information that was lacking was standard information on cost of healthcare services. And this was also important and relevant because of the kind of heterogeneity that exists in the cost and the healthcare delivery structures, which meant that costs could vary across different regions, different types of levels of healthcare delivery. So a national health system cost database was established, and this database included the information on healthcare services for both the primary and secondary level. But even this database, given the available information on cost, did not have evidence for the costs that were incurred at the tertiary level, which were the more specialized kind of healthcare services. Next slide, please. So as a result, next slide, please. Yeah. So as a result, there was a need to have another parallel study that was to be initiated, the purpose of which was to actually establish certain reference costs that could be used for not just the health technology assessment, but also for even price setting under the national insurance program. And this study is a large study being carried out over a sample of 100 hospitals, both in public, private sector. And the estimates of costs that are being generated from this study are being fed into the database, as well as you can see on the right side, these are the estimates of this study in terms of cost of healthcare services are also being used for the purpose of price setting under the publicly financed insurance schemes. Next slide, please. The other piece of information that we felt was quite deficient at the time when we started setting up the systems was information on the quality of life tariffs for Indian population. And at the time that the HTA system was established, we were using, because cost utility analysis was being recommended for the conduct of HTA studies, we were using the Thai value set, and considering the tariff values, given the contextual differences, culture, region, incomes, etc., there was a need to have an Indian population specific tariff values using the EQ5D value set. So as a result, this study was commissioned, and then a value set for the Indian population was generated, which is now being used for HTA studies in India. Next slide, please. Next slide, please. Yeah, so in terms of what has been done so far, I think there have been, the slide is still a couple of months dated, and the numbers have still grown up even further. I think the number of studies that have already been completed are not 13 right now, but they've crossed about 23 or 24. And there are quite a number of studies that are also in progress that are being conducted. There are certain large multi-centric studies, as I referred to, for both costing and value set that are being carried out. And for certain diseases, again, there are independent multi-centric studies that are currently ongoing. For example, one study that is being done, it is for the field of cancer, because there was a need to have some kind of price regulation for cancer drugs, and there was a lot of deficient data in the field for the purpose of cost of cancer treatment. So there was a specific study that was commissioned for this purpose. Next one. And the areas where the HTA studies are being put to use for policy purpose range as was being shown by some of the previous colleagues as well in their presentations. So there are a number of applications for which the HTA evidence has been put to use, either for the development of the benefit package. For example, I've shown some examples in the boxes below, and some of the areas are shown on the boxes at the top. The second application is for the purpose of selecting efficient delivery platforms. So whether it is screening for cervical cancer or screening for, let's say, breast cancer or head and neck cancer. So what should be the most optimal way in which you should organize your screening program in terms of the population being screened, in terms of the methods being used, or in terms of the frequency at which you should be screening the population. Then there are a range of applications that the HTA studies, and there are some examples that I've cited down below, where some hepatitis C drugs were evaluated in order to set the treatment guidelines, not just for a reimbursement program that was being undertaken in one of the states, but also for developing the standard treatment guidelines for the national viral hepatitis program that was for which the guidelines were being drafted at that time in India. And lastly, the decisions around regulation for both pricing and procurement are also being undertaken based on the HTA evidence that is being generated. And two of the classical examples that I've cited here is one for the use of, there was a new type of device that the government wanted to introduce, which is the safety engineered syringes, where the evidence from HTA study was put to use in order to set the prices. And also for now, more recently, as I was talking earlier as well, a number of anti-cancer drugs, almost 40 number, that have come under price regulation since they've been included in the essential drug list. Their prices are being determined based on the evidence on HTA study that is being currently carried out. Next slide, please. So this slide shows basically some of the decisions that were being undertaken by either issue of a government order, where clearly there was a linkage shown between the evidence coming from the HTA study. So I've just put in an excerpt from one of the government orders issued at the state level, which clearly cited that keeping in view the comprehensive health technology assessment report, which provides the evidence, so they've made these decisions on the use of safety injection use. So it's not just that these are being discussed and these are being taken into consideration. Some of the government orders clearly cite the linkage of the decision being undertaken and the evidence that is being generated through the HTA study. Next slide, please. And this is my final slide, where I would say that still I would consider the developments on HTA front in India still a work in progress, and there are numerous challenges that still exist. Some of these are being addressed through various attempts and innovations, but then these are things that would take still the next 2 to 5 years to sort them out in the right direction. So the first challenge remains around the human resource capacity. So despite having several institutions that have been created for conduct of HTA studies, there's a lot of varying capacity within the human resources that are employed in these institutions. And although there is a concerted effort towards trying to organize courses, workshops, webinars, and programs to build capacity, still there is still a gross mismatch between the extent to which the number of topics are submitted to the HTA agency versus the number of topics that can actually be taken up, as well as the time or the reasonable time frame within which these can be reverted back to the user departments. The second is around the user perception. So a number of times the HTA evidence is looked at as something that sort of tries to put boundaries to the extent to which the clinicians could make decisions, or boundaries to which the policymakers need to consider or consult the evidence. So, and some people may do also consider HTA as something that is likely to be used for disinvestment decisions in a setting where you are still way below the mark that you need to reach in order to invest adequately for universal health coverage. So given that the state at which we are arguing much more for enhanced resources to be allocated to the health department. When you talk about HTA, in some quarters it is seen as something that is a tool for rationing of healthcare resources. So that kind of user perception also needs to be corrected through appropriate stakeholder consultation. A lot of efforts that are going towards process consistency through development of guidelines, manuals, and trying to ensure that quality guidelines or quality benchmarks are being met. Again, as I mentioned, data availability and quality is an issue which is being addressed through development of standard databases, value sets for ensuring that HTA studies are conducted in a timely manner. And the final challenge that still remains in a country like India is that there is a vast, relatively unregulated private sector. And the financing system still currently operates largely through a kind of a multi-payer system. So in such a context, even if there's an HTA evidence that gets generated, the extent to which you can enforce the decisions of HTA for policy use or make that kind of universally applicable are relatively limited, because the decisions for a healthcare use are based on a kind of a discussion or a negotiation that takes place on a case-to-case basis between a consumer and a provider. However, with introduction of single-payer systems such as the national insurance scheme, which has been announced, which is the Ayushman Bharat, there is a greater leeway towards use of HTA evidence for policy decisions. So I'll stop here and would be happy to answer any questions that may be there. Thank you very much.
Thank you so much, Dr. Prinja. That was such a fascinating presentation. And we really, really appreciate you being here with us today. There are some questions in the chat. If I may just start off with the chat questions first. So I think someone wants to know, how much is HTA currently used in India and for which purpose? I think you've addressed some of this already, during your presentation. And then they'd like to ask, is there any mandatory subsidy resulting from HTA anywhere in India? Thank you. Over to you.
Yeah, thank you. So as I said that we do not right now have a kind of legal enforcement towards use of HTA for policy decisions. So it is not it is not mandated by law. It still remains a recommendatory body. To the extent that the topics are submitted by the user departments, the evidence is generated and reverted back. In several of these cases, we have seen that the evidence has been used for the purpose of policy making, and the examples have varied from preventive programs where the evidence has been used to guide the development of the appropriate design of a policy or a program, or it could be whether or not to use a particular drug or a device for reimbursement. So there are various sort of applications where the evidence has been put to use.
Thank you. And just one more question, please. So, for given what you've just laid out for us, and the progress and the challenges that we face in India and the way forward, what kind of existing academic or data systems infrastructure did you find to be helpful to enable HTA progress in India? Do you see a need for other countries to build those kind of systems and put them in place first before they do HTA?
Yeah, I think absolutely. So the first year or a couple of years, it was an absolute struggle, because for every study that you conducted, you had to collect primary data for assessing the cost of healthcare services. You had to do patient level data collections for assessing the quality of life for each of those conditions that are being addressed. And this is even more difficult in a setting like ours, which could be similar in a lot of other LMICs, where you do not have very good systems of electronic medical records that could help generate quick estimates of cost or quick estimates of real world effectiveness. So as a result, I think that two very important pieces of data systems that you need to put in place are a kind of database or a repository that helps you assess the cost of different kinds of healthcare services. That's, I think, one very key thing. And the second is a value set for the utility values that you could use in your context. I think these are two very important and key prerequisites that each country, which is in the process of just initializing or sort of setting up the systems, should consider, definitely. Over to you, Prof.
Thank you so much. Colleagues, we have a few minutes, I would say about 5 minutes. So we'd like to open it up to everybody. Open floor. If you have any questions, please raise your hand, use the icon to raise your hand and ask any questions of our presenters. We still have Dr. Kavechi and Dr. Prinja online. The floor is open. We see Ms. Daisy Sembrano. Go ahead, please. Floor is yours.
Hi, so thank you for that. Yes, I have a question to the earlier, the first speaker. He mentioned something about adopting and adapting cost-benefit analysis. And I was just curious about what sort of tweaking can be done to the formulas associated with doing that. Thank you.
Hi, thank you so much for the question. I think the question was about adapting and adopting existing HTA studies that's already been done. So we go through some great details in the HTA roadmap, which is now available for the public. I'm sure our colleagues here can put it on the chat here as well. So in the HTA roadmap, we looked into some of the methods that we can use to adapt and adopt previous HTA studies. So one of the ones that we discussed today was from Drummond, looking at the transferability of the previous HTA studies. This is also something that Professor Ravia Kavechi had mentioned about using the adaptability of other studies that's already been provided out there. So those are some of the things that we can use, whether it's not necessarily tweaking the formulas, but also looking at some of the data that are which ones are transferable. If all of them are pretty much transferable, can we just use all of it? But if it's only some certain aspect, the health benefits aspect are transferable, then we use that. But then the cost is probably something that requires local data. That is another one that's for considerations. So yeah, we mentioned that in greater detail, and we'll put it on the chat here. That please feel free to explore and see some of the options that we lay out to be able to do this kind of referencing and adopting and adapting existing HTA studies. Thank you.
Thank you, Chris. And we'll take one more question, colleagues. And this is certainly a challenging question in itself. And we'll start with Dr. Prinja and move on to Dr. Kulechi and others on the panel to answer this question. So basically, this is what is being asked. What are the new challenges in performing HTA during this pandemic? How have you addressed these challenges? Or do we need to tweak the processes in place for HTA due to this pandemic? What changes are we putting in place and what processes are we changing to meet this challenge that we all find ourselves in? Thank you. Over to you first, Dr.
Yeah, sure. Thanks, Taj. I think, as you said, it's a very challenging question. See, the pandemic posed challenges both in terms of the process in which the HTA was to be carried out, as well as in terms of the methods that you had to put in certain adaptations. In terms of the process, I think one of the major changes that came in was that there was the speed at which you were expected to generate evidence was by far unprecedented, because the decisions had to be taken in very short time frames. And so you did not have the luxury of getting the best data, collecting any amount of primary data as well. And secondly, the extent of data that was available in the secondary literature as well, for a lot of interventions that needed to be evaluated was relatively much scarce. So you had to be relatively smart enough in order to make the best possible decision given the available evidence, because the best data may not necessarily be available. The second question the second thing that was there was in terms of the methods adaptation. I think that prior to the pandemic, even a societal perspective that we may be taking for assessment of cost utility analysis would only look at the limits within the health system for assessment of either costs or valuing the consequences. But I think the pandemic posed issues that went beyond the health sector, and there were large multi-sectoral issues or multi-sectoral implications of the interventions that were being brought about within the health sector. So whether the interventions were lockdowns, non-pharmaceutical interventions, or even the pharmaceutical interventions, because whatever impacted transmission of the disease, the effects of that went beyond the health sector. So you had to factor in those societal implications and consequences of the healthcare interventions as well. So those were I think some of the challenges and some of the adaptations that had to be.
Thank you so much. Anyone else on the panel who would like to tackle this question?
Thank you. Well, actually, I also saw a very good question to me in the chat box.
Yes, so, go ahead, please.
I wanted to answer that one. For COVID, I think yes. Already gave a very good response. There's also a question in the chat box for myself about how the policies in Ukraine match with the European Union. I think what is very important here, Ukraine is a candidate for the EU. I had the same experience with Turkey. I'm from Turkey, and Turkey was a candidate for the EU as well. So you have some certain right to align your processes with those ones. But on the other hand, the realities for these countries are very much different. So for Ukraine as well, EU is a good benchmark. And there's also official requirements that you have to align your processes with EU. But on the other hand, most of the countries that have very well established HTA functions in those in that region are high-income countries with very well-established healthcare systems and so on. So the thing here for Ukraine was, first you want to align yourself to EU, but on the other hand, you have to be realistic about your facts. And I think there was a very good work about this one. So we have the benchmark from those countries. We use the methods published in Ukraine are totally in line with European guidelines, and they were all reviewed and adapted to Ukrainian context. But on the other hand, the processes are not exactly the same. In Ukraine, currently, it's only pharmaceuticals, not other technologies. We know in Europe, many other technologies are also reviewed. The initiation is from industry submissions, so the dossier comes from the companies, which I would say more closer to Poland, for example, or Turkish example, other, but I would say there are unique positions in this country. But what is also very good for Ukrainian context, I think, which is in line with the question, legalization has happened very quickly, so it is being totally engaged in the decision-making process legally, makes the impact higher. Because if you do not have this one, has the same, if it's not legally based on a strong ground, then it remains like it's ourselves closer to good examples in Europe.
Thank you. Thank you, Rabia, and thank you both for that very informative Q&A session. Now we're exactly on time to start our breakout sessions. So if we could just have the slides back up, please. Okay, so while we wait for those slides to be projected, let me go ahead and say that we are now entering an exciting part of our session. The purpose of this breakout is to invite all of you to share your thoughts on the HTA roadmap and how you may apply the information in your country. So we'd like you to identify a top priority for implementing HTA in your country and give us some specifics on what your technical assistance needs might be. So we will have 7 breakout groups. So before I go into those groups, let me just again bring your attention, please, to the slide here. Here's the purpose. We want to hear from you about the HTA roadmap, and we also want you to identify what a top priority is for implementing HTA in your country. So next slide, please. So there will be 3 discussion questions. So you will see them on the screen. I will not read them out to you. I'll give you a minute to process those questions. So over the next 30 minutes, what we'll be doing is asking you all to self-select a group and try to answer these questions as best as you can during the group discussion. The first question, you will have 12 minutes to answer that question within your group, another 12 minutes to answer the second question. And finally, we ask that you summarize your discussion in the last 6 minutes. So this is 30 minutes in total. And when the 30 minutes are almost going to be up or completed, the breakout sessions will automatically close and we'll go back to plenary to do a report out of what the groups discussed. So when we're back in plenary, you will have about 2 minutes to summarize the discussion from your group. We know 2 minutes is not enough time, but please, we ask that you think through what you want to bring to the plenary from your group. Next slide, please. So here are the groups that you'll see on your screen. right? Group A is Indonesia. Group B has groups B, C, and D are for the Philippines, because we see quite a few people from the Philippines here. Group E, the countries on your screen: Afghanistan, Bangladesh, Bhutan, India, Laos, PDR, Mongolia, Pakistan, Sri Lanka, Vietnam. Group Group F, I skipped Group F: Australia, China, Japan, Jordan, Kazakhstan, Lebanon, Malaysia, New Zealand, Saudi Arabia, Singapore, South Korea, Taiwan, Thailand. Group G is other countries. So we have these 7 groups, and now we ask that you please join a group and let the discussion begin. To do that, let me start by inviting each group to do the reporting out. We hope you have a volunteer to do so. So let's start with the first group, Indonesia. Go ahead.
Hello, Taj. Hi.
Yes.
So my name is Rosa. I'm speaking using Pak Arman Shah's Zoom account. Sorry, because of the audio problem. So I'm going to report what's in Indonesia's breakout room. We don't have much of a discussion, but we almost all of us agree that Indonesia is finding its own format of like in terms of institutionalizing its HTA processes, and we discussed about several challenges. One participant expressed the needs of standardizing the HTA processes, including costing, economic evaluations, and but in terms of sustainability of the HTA agencies in Indonesia, we would like to strengthen the funding to the National HTA Commission. So we would hope that we receive some technical assistance in strengthening the policies in order to do so, like to strengthen the links between the Indonesian HTA agencies, the committees, with the national insurance body. That's all I can report to you for now. Thank you.
Terima kasih, Pak Kermansyah. Next group, please. Philippines.
I'll speak for if the rest of the group don't mind. Philippines group C. So we have identified Philippines as an emerging and growing HTA system, and what needs the technical assistance that we do need to improve and continue growing is first technical assistance improving capacity of HTA, both in terms of how many are doing it, the network research networks, as well as the expertise and knowledge of all those involved, with the government as a priority for the capacity building. Also, we need to improvement in the monitoring, evaluation, and learning. I'm sorry, I cannot turn on my video because my internet is not working well. So yeah, I just continuing improve. So we need TA to improve monitoring, evaluation, and learning for the Philippines as well.
Thank
So
you.
that's all I can share.
Thank you, Ms. Joy Salamat. Sorry about the internet difficulties, but this was fantastic. Thank you for those inputs. Next group, please. I think that's group E, if I'm not mistaken. If you can just raise your hand. Yes, please. Go ahead, Gursimar. Thank you.
Yeah, I'm from India, and regarding India, I would say that the stage of the journey of HT in India has so far been
recording stopped.
It is emerging. The area is emerging and growing, and there has been good support from the political leaderships and policymakers, as well as research community as such. And it is still in its initial stages, I would say, and we will definitely require more evidence that the decisions are being shaped through HTA and have positive impact on the health outcomes in coming years. And for India specifically, I would say that more investment is required in building capacity to support the HTA research, and overall to ensure that whatever the research evidence is being generated, it gets changed into meaningful policy statements. Health system strengthening is going on at a fast pace, and is being spearheaded by the Secretariat especially, and we need development of standard treatment guidelines, which are already in place for many diseases, and states have prepared separate SDGs as per their state's requirements. Finally, there will be, we will need greater stakeholder participation, and considering the multi-stakeholder involvement in HTAs, the participation by different stakeholders and sectors should be ensured. And finally, greater dissemination of evidence, and a body which can help researchers and policymakers to manage if any potential conflict of interest that may arise. And I think, summarizing, I would say that we are still in our early stages, and we will keep on requiring this good political will that is already being provided to the HTA-IN.
Thank you very much for that summary. And to Group E, Group F, please. If you could raise your hand, floor is yours.
Hello, can you hear me?
Yes, please go ahead.
Yeah, I can go with for Group F. We had a representation of 3 countries for Taiwan, Malaysia, and Singapore. So in terms of status of current HTA, well, I don't have the notes in front of me. I know somebody was taking notes, but I don't know where they are at the moment. But in summary, Taiwan is a sort of a 100% fully subsidized markets. And HTA has been in place for quite a few years. However, is not as developed as markets like Australia. All drugs go through HTA in Taiwan already as a standard process, and we had a representative from the Center of Drug Evaluation that disclosed that approximately 80 drugs were submitted for evaluation last year, with a staff for only 40 people. So one of the current issues is generally manpower. The other issue for Taiwan was that although it's a universal coverage system, certain high-cost medications have not been recommended, such as the sort of oncology immunotherapies and cell and gene therapies. And the Center of Drug Evaluation is working closely with the NHIA, that is the national body for pricing and reimbursement, and the Ministry of Health to establish a framework for evaluation of cell and gene therapies. For Malaysia, also subsidizes drugs as part of a health technology assessment. However, not all medications undergo health technology assessment. Subsidy is generally provided free of charge with a small copayment of 5 ringgit, which is about, I think, just over $1, just over USD, for patients. Again, although most medicines are funded subsidized by the government and on this blue book, then again, most of the medicines are the relatively inexpensive ones, and high-cost medications are often paid out of pocket. The representative from Malaysia also mentioned that there is a need for more communication across the agencies of the Ministry of Health. They often don't know, sort of the right doesn't know what the left is doing. There's also need for data availability in order to improve access and adoption and evaluation of these medicines. And finally, there's a potential need for improved infrastructure. Finally, for Singapore, HTA has been in place since about 2015 with the establishment of the Agency of Care Effectiveness. However, HTA has been mandated and executed by the agency from their side. And a pilot in oncology has been established for manufacturer-led submission process just now in 2021, starting in April. In terms of what's working well and less well is, first of all, this process is very expensive, about the same as it would cost in Australia and the UK for submission of an application. But Singapore is obviously a much smaller market with about 5.8 million people. And only about 75% are actual Singaporeans that may benefit from this framework. So one of the issues is that several manufacturers may not be interested in highlighted in the past 12 months or so has been the transparency in the conversations between government and manufacturers in general. From my group, anything I may have missed? Okay, that's all.
Okay, thank you so much. That's appreciated. And now we're going to go to a quick poll before we close. Can we have the next slide, please? 2 questions here. I'm sorry, my apologies. 3 questions. So the first one, please vote. Which one would you prefer now? It's a single choice, precise or practical. That was question number 1. Question number 2, is this true or false? Whether a country's existing HTA capacity strongly determines their HTA next steps. And the last question, as you can see on your screen, the poll will be closing in about a minute. We are going, and done with the poll. So can we see the results, please, Luciana? Thank you. All right, so quick wrap up here. The first question, I see 83% of our colleagues today said very practical. All right, and of course, 91% picked true, as a country's existing HTA capacity strongly determines the HTA next steps. And then for the question number 3, we see, as you can see here on your screen, we have about 61% who said HTA and real-world evidence would be most beneficial for their country, followed by 50% who said that HTA and value-based purchasing. And then we have 43% talking about HTA and multi-criteria analysis. And then HTA and benefits package design, followed by pricing of commodities. And last but not least, advanced market access. So thank you so much, colleagues. Thank you so much for your participation today, your time and attention. This has been a very productive session, and we hope you've learned from this as we have from listening to all of you. We thank you for your attention to this very important topic, and we want to close by thanking, of course, our sponsors, our funders, US Agency for International Development, the Asia Bureau, DERIN, the Ministry of Health, Republic of Indonesia, CHEPS, HTAsiaLink colleagues, the conference organizers, all of the presenters and speakers, Dr. Rabia, Dr. Shankar, Dr. Rea, Dr. Christian Sahalim, our team in the background who's been very patiently, doing all the work, Akshay Mehra from MSH, Julie Huang from MSH, and all of the colleagues, the conference organizers. We really appreciate, your time and effort smoothly. So thank you. Thank HTAI attention to this very important matter. So I hope we're all on the path, on our respective pathways to achieving our goals for universal health coverage, and hope the HTA roadmap will take you there. So thank you for your time and attention, and goodbye and good luck and take care. Stay healthy, everybody. Thank you. Terima kasih.